children. In particular, he loves his subspecialty, if I may put it that way, of private practice. And he very much desired that every pediatrician, especially those in private practice, does the correct thing for their patients. And he was very instrumental to our forming of this group. He would encourage me, he would call me, and he was full of support for this group. A day like this brings home the reality that he's no longer with us more than anything else, because we would expect him to be here. He normally joins this meeting and is one of the first to join the meeting. And on the days that he doesn't join, I would notice and I would call him after the meeting. Or he would call me if I don't call him in time. And he will ask, how did the meeting go? And I will ask how he's keeping. And he always ends up with words of encouragement and support for this group. He loved this group. Today, there will be nobody to call. I will not be able to call him and he will not be able to call me. But we take solace in the fact that he lived a good life and he lived a great legacy, both himself and Professor Kiahalam. And we that are remaining, we must keep their flag flying. That is the least we can do in tribute to the great work they have done. May they rest in peace. I wonder, can we just observe a few moments of silence in their honor before we continue? Thank you. May their souls rest in peace.
Amen. Amen.
Over to you, Dr. Eletu. Over to you, Dr. Eletu.
Thank you very much, sir. And, I want to join in saying that we definitely will miss two great patrons. So today I will be introducing briefly somebody I've known since medical school. We got into medical school same day, and I can almost say on the 2nd of December 1981. So only to tell you how much I remember. He is a professor of psychiatry, and we finished at Ahmed University in 1986, and then we both ended up at Arrow, the neuropsychiatric hospital in Abeokuta. But he was very brave to continue while I ran away after one difficult night call. And I decided that psychiatry was not my calling, so I ended up in pediatrics. So it's no surprise that our paths have crossed so many times thereafter, and here we are today. Kole has done quite a lot of work in psychiatric the setting all over the world. I know he was at some point in Liverpool before he decided to cross over to Canada. And one thing you should remember about him is that he's a lover of high life music. And he says to me, that's the only music played in heaven. So I'm sure today will treat us to a very good meal as a psychiatrist. And Kunle, I hand over to you. The floor is yours. Thank you very much.
Thank you very much. Good morning, good afternoon. It's a pleasure to be here. And yes, Eletu, as we call him, there's a plural for Eletu, is Eletai. And when you have a classmate like Eletu, you better be careful because he gets you on your toe all the time. I haven't played soccer for a while, but he used to be the one that pulled us to the field. So it's a pleasure to be here to join you. Dr. Lowell, thank you very much for the introduction and for the warm reception. I think I've seen a few face names that I think I know. There's Laolu. Will that be Adebowale? No? Maybe it's a different Laolu. But if it is, whosoever it is, it's a pleasure to meet you virtually. And Dr. Orode Duarte was my guest. And she was one of the bold ones that came on I think she was on Doctor's Round. That's another interest of mine. She was on Doctor's Round. Great job, man. And thank you again. Nice to see you. I've been told to come and talk today. I'll share my slide and I hope I can make it exciting talking to a group of okay. Can you see my slide? Can you see my slide?
Yes, we can.
Yeah. Yes, we can.
Excellent. Thank you very much. I'll just go to slideshow here. All right. I'll be talking about insights into personality, recognizing and responding to early signs of character pathology. I'm a forensic psychiatry. The bane of my practice is personality disorder. I can't live without talking about personality disorder, which is the main thing. Is my slide changing? No?
No, not yet. You can try again.
Okay, thank you. It's not changing. It's not changing. Okay. Thank you. Yeah, okay. My apology. As we always do here, we've got to pay respect to the owners of the land. I'm presenting to you from Treaty 2, 4, 5, 6, 8, and 10, territory and homeland of Métis. I pay my respect to the First Nations of Canada and Métis ancestors of and reaffirm our mutual relationship. They own the land. And since I'm transmitting from there, it's a duty for me to pay that respect. I have no declaration of conflict of interest whatsoever. I'm going to be talking about personality or traits, early childhood traits. And I hope that at the end of today, we'll be able to reflect. These are things that you do as as pediatricians. We'll be able to reflect on character pathology in childhood. We'll be able to talk about 2 samples of what grows up to become my problem, because your finished product are my problem. If you did a good job, I'll be happy. So I'm not doing this for free. There's something to be gained by doing this presentation. And I hope to talk about the prognosis of delayed recognition of childhood pathology that becomes my problem. I used to have afro, but unfortunately, when things are not detected early and I have difficult patients, I've lost my hair from those ones. That's why I'm bald-headed. Talking about the telltale sign of character pathology, you taught us the attachment theories. You taught us about the function of bonding, good relationship, and secure attachment. I'm not going to be talking about all those. Those are your areas of specialization, but they cause trouble for me. Having early signs, recognize and responding to them actually help to save the kind of cases that come forward. Why am I bothered? This is one of the reasons I'm bothered about this. Antisocial personality disorder and the malignant form of its psychopathy show very early in life. And if we do not detect it and respond accordingly, there's a problem. What then the characteristics of individuals with antisocial personality disorder? They live an impulsive and chaotic lifestyle. They have emotional disinhibition. They have low frustration tolerance. They're prone to be bored. And they have difficulty in engaging in productive activity or to solve problems. You can always think about the childhood manifestation of this from very early age, the temperaments and the difficulty you have. A lot of children may grow out, but we know that 2 to 4% of the population do have criteria they fulfill they meet the diagnostic criteria for ASPD. Of course, males are more, but we see them in female. And the reason we have less in female is because of misdiagnosis. Most of the time, they diagnose them as borderline personality disorder, but really, there's a significant proportion of females that come with antisocial personality disorder. There's also high comorbidity of ASPD with substance use, depression, and anxiety. And there's a need for us to start distilling this. Of course, in childhood as well, you find children presenting with cantankerous behavior, which is early manifestation of this problem. And in terms of diagnosis, you don't need to bother yourself with that, but your oppositional defiant behavior leading to conduct disorder and leading to ASPD is a well-known pathway. And if you can pick kids up when they present with oppositional defiant problem and we start responding to it, then we're likely to have them better. We know that individuals, both across age group, individuals who have temperamental problems tend to come in conflict with the law earlier. There's minimal, in these individuals, they also have minimal neurological problem or deficit. We can't find anything in the group of this patient. They are a different group that have frontal lobe damage that I tend to see. But in this group of patients that I'm referring to, you can't find anything. We know that these individuals engage in multiple and repeated and increasing frequency, types, and severity of conflict with the law. This is the sort of thing that you see. And they tend to be more reward-oriented. They want, there's dominance. They're thinking about, what am I getting from whatever relationship? Relationship are transactional, and it is. It is. And we need to start paying attention to this because if you're looking at the etiology, is it poverty alone? Is it other things? Because I see certain things that are developing in the country when I go back home now. Every kid wants an uncle. What comes with that? And it strikes me. I wonder if antisocial trait is becoming something that it's been normalized. We need to start paying attention to it. Such factors also that are associated with adolescent problems that may even go into psychopathy is deceptive, they're arrogant in their interpersonal relationship, they're callous and unemotional. And these are all detectable at a very early age. Impulsivity, irresponsibility are also common traits that we need to start working for in these individuals. We know that children with ADHD show psychopathic traits, but are not necessarily psychopathic. But they show the trait. It is the onus is on us to have to make sure we identify this and have to tease it out. Generally, individuals with ADHD, we know that there's also a high prevalence of early adversity. There's also pre and perinatal adversity that must occur. There may not be factors that you say they are familiar. Not necessarily because the home environment, but ADHD, because of its organicity, we know that may also present with things, traits that we need to be very concerned and identify early. ADHD and psychopathic, they correlate with unstable and antisocial lifestyle. So when you have ADHD and you have psychopathic traits, they tend to constellate together, and it's very important in terms of recognizing those psychopathic traits in addition to ADHD, so you can start early intervention. That's what I'm trying to stress here. We also know that ADHD and personality may not be related at a symptom level, but one thing that seems to be very common among all of the two of these individuals is impulsivity. So paying attention to impulsivity is very important. As a forensic psychiatry, I know that the prevalence of ADHD is very common. We have about 40 to 45% of the inmates have ADHD. And we know that ADHD persists into adulthood. We may not be breaking grandma's figurines by jumping around, but then we may be having multiple relationships. We may be having difficulty tolerating others. We may be having difficulty with anger control, and that becomes a problem because we didn't manage it early enough. So ADHD is not something that is just related to childhood. We see a lot of them. So that's the background in terms of what we're looking for: antisocial personality presentation, antisocial behavior, impulsivity, they're telltale signs. And those are things that lead up to who I see as a forensic psychiatrist. I'm now going to focus on human disorders that typify the traits that I'm talking about. Conduct disorder. I don't have to go through it. You're all familiar with the clinical presentation, but these are the characteristic: persistent, repetitive and persistent pattern of behavior in the form of violation of other people's right. We know that this individual also present with aggression to animals and people. They often bully in school, threaten, they intimidate others. They present with all those features that is a violation of other people's right. They may destroy properties and deliberately engage in fire setting. We tend to look at that. Of course, your enuresis, you remember those things that we asked, whether or not you have secondary enuresis or primary. They tend to be very common among individuals with conduct disorder. And the more of the aggression, the subset of patients that have that are aggressive and show lack of empathy, those ones are more likely to grow into personality disorder. And in fact, we know that those ones are more likely to become psychopathic. The other areas is that these individuals can be deceitful. They may engage in stealing from others. They tend to cause serious violation of rules. And of course, it is advisable that when you see these individuals, those specifiers in red are of importance to me as a forensic psychiatrist, because those are the ones that really grow to become a major problem. they become my clients. Lack of remorse or guilt, callousness, inability to display empathy, shallow affect. If you look at the criteria, Hare's criteria for psychopathic traits, you discover that these are the things that remain. And if you go into the future, these are the things that determine, the features that determine who will really be a problem. Disruptive mood disorder regulation. This is a very interesting disorder that just came, that has just been recognized within the DSM system of classification. And there was a lot of debate because there's an interest group in anger. There's so many ways you can be depressed. In psychiatric disorder, you can have dysthymia, you can have major depressive bipolar disorder with depression, but there's really no way you can be angry. Anger is not recognized as a diagnosis itself, but we know that individuals who have anger problem present, and they present frequently to forensic practice. And we had a lot of debate at the American College of Psychiatrists, debate on at the APA in terms of having a nomenclature for individuals with anger disorders. That's an area of interest of mine. And unfortunately, the pharma company and the sensitivity towards pharma company really militated, went totally against having a diagnosis like that. The best they could do is that the same thing with personality disorder, because psychopathy is not in personality. If you look at psychopathy, which is a very severe, disruptive, dangerous, malignant form of disorder, it's not available in DSM. So disruptive mood dysregulation disorder appeared to be the best compromise in order to attend to this individual. And it's important that we lay emphasis on these in order to start the preventive work. So this individual tend to present with severe recurrent outbursts of anger. It's either verbal aggression or physical aggression. These individuals the mood outbursts tend to be inconsistent with their age of development. It's just so disproportionate. And you can't find anything for it. If you think about the intermittent explosive disorder, this is actually more frequent. Intermittent explosive disorder, they present with their disorder. I'll try to do a distinction, but these individuals, it is very irregular, and anger seems to be the major presentation. It occurs on average about 3 or 4 or more times a week. And the temper outburst is persistent. They're irritable between episodes, and that can be very disruptive to the family. It's also not located to any particular place. It happens in school, it happens everywhere. This is one of the major problems that we need, at least in the North American practice, that we do not attend to. So increasing sensitivity and our diagnostic radar is very important in this sort of cases. This table here that I show is to help us just reorientate ourselves in terms of distinguishing characteristics of these individuals that present with severe character pathology. So you have conduct disorder, you have DMD, ADHD, intermittent explosive disorder, and bipolar disorder. And you can see, I want to pay attention to the mood here. you can see that in conduct disorder, mood as a criterion is not significant. But in DMD, mood is a problem. ADHD, yeah, they may have irritability and so, but it's not a prominent problem. In intermittent explosive disorder, it is certainly a problem. So when you have your 17, 18-year-olds, this is very important to consider. And of course, manic depressive disorder and irritability present depending on the phase, and the anger can be directed outwards or can be directed inwards. One distinguishing characteristic is lack of empathy, and kids do show these. Mother tells you that he's never sorry about hitting the sibling and just walks away. It's an early sign that we need to pay attention to. For the DMD, empathy is intact. For ADHD, not impacted. And of course, it's not impacted in intermittent explosive disorder. An individual with intermittent explosive disorder will actually come and apologize and say, I'm sorry. That was gross. That was so disproportionate. And of course, for bipolar disorder, if they're in the manic phase, they may manifest with grandiosity and claim that, well, it's part of their right to be angry and so on and so forth. But when they're settled, when there's no more mania, they regret what they've done and they apologize, they have the capacity to show empathy. So that kid, 16-year-old, is able to say sorry, even though he believes that he was the best since sliced bread and behave and claim authority, entitlement, and so on and so forth. The opposite is expected when they're in the depressed phase, of course, because that's when they feel down in the dumps and want to kill themselves. So what I'm trying to lay emphasis on is this empathy bit. And if we watch out for that, we'll probably be doing a lot of preventive work. The other area of focus here is the nature and the episodic nature of it. You discovered that things like conduct disorder is persistent. See, persistent all the time. If you look at ADHD, the disorder tend to be more manifest in structured environment. It depends on the environmental structure. If you're in class, you're in an organized area, you see more manifestation. Where there is constraint and the individual has to follow the norms, may be a problem. And of course, bipolar disorder is episodic, as we're well aware of. The final thing is comorbidity. Generally speaking, conduct disorders they do not have as much comorbidity. In fact, if you see comorbidity, you got to be sure that you've treated that first, but most of the time you don't find any comorbidity with conduct disorder. Whereas if you go to ADHD, you may have anxiety, you may have depressive disorders that are associated even as in adolescence. You may find them presenting with that. And of course, that has treatment implication if you're using stimulant. What are the implications of all this? I haven't said this. These are the early risk environmental factors for ASPD. We know that parental neglect and abuse and in the form of childhood maltreatment are significant factors in terms of the etiology of the disruptive family bonds is also very important. Engagement in and exposure to externalizing behavior problem, aggression in the home, teasing, bullying correlates with development for ASPD in the future. Childhood treatment, maltreatment associated with a range of adult psychopathology, personality psychopathology. Depression and personality disorder in childhood correlates with that. High childhood maltreatment groups we know significantly show symptomatology across a wide range of other psychiatric disorders and personality disorder, including ASPD. Individuals that present with narcissistic personality disorder are known to have significant childhood maltreatment, and it's probably a form of defense mechanism to get rid of whatever the sort of way they've perceived they've been treated in childhood. Childhood physical abuse and neglect are significantly correlated with ASPD as well. And ASPD predicts childhood sexual and physical, is predicted by childhood sexual and physical abuse. A significant proportion of those who are abused in childhood end up developing that. Childhood victimization was a significant predictor of a number of symptoms of ADHD in adulthood. In summary, where we see childhood physical and sexual abuse, they're consistent. We should be very suspicious of ASPD developing, and the earlier we start addressing that, the better. So, what is the cause generally of individuals who have conduct disorder? In infancy, they might have had some injury. They might have presented with emotion dysregulation, difficult temperament, attachment problem. They may have delay in their physical and emotional growth. In childhood, they may present with anxiety and mood disorder, ADHD, behavior difficulties, low self-esteem, peer difficulties, and academic problem. And as they become adolescent, then we start seeing signs of conduct disorder, substance use disorder, suicide attempt, risky behavior such as unprotected sex, and eating disorders. Dating becomes a problem for them. And as adults, they arrive in that personality disorder cluster. They may have other chronic physical, chronic disease and pain, relationship difficulties, and interpersonal violence becomes they perpetrate in interpersonal violence. So they will be the spouser, the individuals who are abusing their spouses, and they in turn start mistreating their children. Unfortunately, it doesn't stop there, because as old the age, they're now 65 and above, they present with depression, decrease in life expectancy, and they may have financial difficulties. And what about individuals with dysregulated emotion disorder? We know that before age 10, 80% of the patients who have this disorder will still meet they will still meet that criteria. It started 6, by age 10, they're still meeting the criteria. So significant proportion retain that full diagnostic criteria. And by the time they become, they're now in their childhood, they're later to adolescent, but in childhood in particular, there's increased risk of depression, ADHD, disruptive behavior, peer relationship difficulty, and they may have relational aggression. Frequent report from school, and all those things they bring to you, they will start showing it here. By the time they become adolescent into emerging adults, you find that they present with serious illnesses, major mental disorder of different kinds, sexually transmitted diseases, and other non-substance related psychiatric disorders. There's increased smoking among them, contact with the police, and of course, they're probably not achieving enough, academically, and they're not productive. So that becomes a problem. So finally, looking at childhood temperament and personality disorder, we know that their character, the way individuals who have childhood problems and temperamental difficulties, the way they present their personality, because of the irritability, the high activity level, fearfulness of some sort, emotional reactivity, and which may not be situation specific, tend to be very common, and it goes on for a long time. Then we know that 30%, about 30 to 50% of individuals with conduct disorder end up developing ASPD, meeting the full criteria. So early signs, so if you detect early onset, the earlier a patient shows features of conduct disorder, the more likely they to develop ASPD. Adverse experiences have indicated in childhood, negative or adverse experience correlates with ASPD. Erratic parenting is also something that is very important. Most of the psychopaths exhibit childhood onset behavior problem. Anempathy, lack of empathy. Most severe conduct disorder children end up as having severe psychopathic traits and behaving in a way. So the key features of personality may persist from childhood. I think that's the message that I wanted to pass here. Looking at those personality traits and thinking of what happened. I'd like to just round up with this slide. I'm not planning to talk about the treatment itself, but this is more in a nutshell, what sort of treatment. Generally speaking, most of the intervention, the investigation, I didn't bother to include all the kind of investigation, what sort of investigation you require. I'm sure you're familiar, but I'm prepared to answer those questions. I just want to say something though, in terms of ADHD. One of the things that I found to be useful, and it doesn't have any cultural implication, is actually the use of continuous performance tests. I think you do yourself a lot of good if you can invest in. Most of the time you send to psychologists, that's what we do, but actually having a CPT that you're familiar with, investing in CPT, I think goes a long way. It helps you to titrate medication, to make diagnosis, to titrate medication, and so on and so forth. So if I use continuous performance tests at the beginning, you can see from the psychophysiological response, you can actually categorize, and I may be able to show if you want me to do so. I have sample on this computer. You are able to see the difficulty with attention. You're able to see difficulty with hyperactivity. You're able to determine aspect of impulsivity, and you can use that to support your diagnosis. And the significant thing is actually when you start on medication, just like you measure blood pressure, you will not allow anybody to start you on any antihypertensive unless they're taking your blood pressure. I shouldn't be starting my patient on ADHD medication unless I've done the CPT-3, and I tend to do that quite frequently, especially in adults. And you can then measure what the benefit is. Stimulants, generally, we know they work very well, but they have two broad effects. There's the main effect at the neuronal level, and there is the stimulant effect. The stimulant effect gets lowered, whereas you retain the treatment effect at neuronal level. The best way to confirm that is to do a neurophysiological test. Otherwise, you'll be chasing the shadow. You'll be increasing the dose of stimulants, because they keep coming to you, especially among students. in the university, they keep coming and say, this medication is not working, can you increase it, and so on and so forth. So what am I saying is important. Quickly, in terms of conduct disorder, basically, family therapy is very important, behavior modification is very important, and pharmacotherapy become increasingly important. And in pharmacotherapy, SSRIs are known to reduce impulsivity. And apart from SSRI, I tend to use, and it's there, there's a lot of evidence for it, using, of course, you've got to be very careful with SSRI and suicidal behavior among children, but the SSRIs are useful. Mood stabilizers, anticonvulsants are very useful. In the adult population, I use lithium, but in children, I use more of mood stabilizer, diaborex, very helpful. Oppositional defiant disorder basically is behavior modification, understanding what's going on. Those are the features. ADHD, of course, pharmacotherapy is the main thing. Non-stimulant pharmacotherapy, Strattera, I found it to be very useful, but in my practice, the response rate is very, I've done combination. I find it as augmentation strategy. That's in the adult population. I don't know what you do. I don't see children. Substance abuse, of course, is also a very important feature. The treatment, I don't know what's available, but usually it's multimodal intervention in the place of practice. And bipolar disorder, of course, pharmacotherapy. I don't know how often you use lithium. I'll rather delay lithium. That's what I would think you do in childhood. In adulthood, absolutely, with frequent renal function test. And the other area that is intermittent explosive disorder, especially in late teens, going into emerging adults. I can't emphasize how much of anticonvulsant that I use in that population, because I'm always afraid of the chronic effect of lithium. So overall, treatment is available and is effective. So that's my show and tell, and I'll be ready to answer any question. Thank you.
Thank you very much, Kunle. Well, we didn't expect anything less. Of course, there are questions already, so you may have to look into the chat box. And just to also let you know, Kunle is a lawyer, so it's not surprising that he's practicing both medicine and law at the same time. So I think the first question from Professor Grange. So you can answer that.
I'm trying to stop sharing the screen here. Okay, here you are. It's hiding away from me. Okay, cool. All right, in the chat box?
Yes. Okay, she's asking what is the role of excessive operation of social media, especially at gaming?
Oh, well, what is the role of excessive? Go ahead, repeat that.
Operation of social media.
Exposure to social media, we know, does have effect, but it depends on what you do on social media. Certainly, it has significant role. One, it limits interpersonal connection. I wonder if you've been to a restaurant these days. Your children are sitting across the table, the young adults, or even not even young adults. I have 60-year-old, they're sitting across the table. It's your birthday, I'm spending my money. They get so engrossed in that damn thing. So my rule is that, no, social media does limit interpersonal connection. Social activities become restricted. We know there's a correlation between excessive gaming and an internet addiction and poor interpersonal skills. I think we're creating a lot of people in our society these days. We're creating children who make friends with robots, but less friends with us. So it certainly reduce interpersonal skills. With reduction in interpersonal skills, you're likely to get into more difficulty. Inattention is a problem when you're in social setting. Without inattention, lack of communication, aggression is likely to increase. So thumbs down for social media.
Thank you very much. I want to ask a question. Role of ECT in managing some of these patients, because I'm not so sure we do that for children, but would that have any role at all?
Well, if you're asking in adults, yes, it has role. But unless you have individuals that you've gone through, for comorbidity, we know that depressive disorder can be comorbid, anxiety can be comorbid, paranoid disorders can be comorbid. In such individuals, when you've done every other thing, you've gone through the cascade, you can use ECT. I don't know if it's available. It's something that I'm not a child psychiatrist, but I think that in instances where, especially in borderline, that is associated with intractable depression, ECT has been used to reduce the aggression that such individual manifests. But as a sole treatment for impulsive behavior, very questionable in childhood.
Thank you very much. If we have questions, we can raise up our hands and then ask questions, or can put their questions in the chat box. There's another question there for you from Michael.
Excellent. Is that the one? This is the one that I'm reading now. Given the overlap and the association with adverse childhood events, are we dealing with a continuum of the same? Well, very valid question. There was the debate about lumpers and segregators is very common in psychiatry. We talked about this. Some people say, well, you get to have separate disorders. Other people say, well, it's just the same condition ongoing, and it appears in all forms of diagnosis. So you can make that argument, but unfortunately, there are distinct behavior. All conduct disorders are not the same. I hope I was able to pass that message. Some conduct disorder resolve. It's not a continuum. I've also talked about ADHD having significant organicity, organic base state that you test it using psychophysiological tests in order to even make a diagnosis and so on and so forth. So they're not the same, and they don't appear to be the same. And if you look at the personal, that's a different talk. But if you look at personality disorder, the clusters, you discover that they have different causes. Individuals in cluster A tend to, if they're going to develop any illness at all, they have coming down with major mental disorders, the paranoid schizophrenia, and so on. Cluster B tend to be more associated with bipolar disorder, and cluster C tend to be more associated with cluster 4 anxiety disorder. So it seems as if the brain is manifesting different pathology. And yes, our understanding of the brain is still very, we're still trying, but it doesn't appear that we're dealing with the same phenomenology.
Thank you very much. Do we have any more? Okay, there's a hand up. Please go ahead.
Yes, that's me, Professor Grange.
Oh, thank you, ma'am. Yes, ma'am.
Good morning, ma'am.
Thank you very much for, I think, for the first time, you really classified the various types for us. You know that there are some which perhaps we as ordinary pediatricians can deal with at the primary care level, and there are others that will need to be referred to specialists like yourself. So I got that message very clearly. Now, in terms of treatment, I believe that experts tend to use pharmacotherapy a lot, obviously, because they will be dealing with the very severe ones. But the milder cases, or I don't know whether there's any case that's mild, but the ones that we think might be resolved by applying primary care measures, like getting them to exercise, getting them to have a good diet, etc. You know, how can we maybe start with that type of management at home before referral? Then there is this stigmatization of the whole problem, particularly at school. And you find that these children don't want to go to school anymore. Is there, you know, in the developed countries, I know that they are beginning to set up special schools for them. Is this solving the problem? You know, these are the intricacies of the illness that I thought, you know, you should please enlighten us about. Thank you. Thank you very much, Kunle. It seems that there are, you know, every Kunle goes for psychiatry. Eh? Okay, right.
Thank you very much. Thank you very much. Thank you very much, man. I think you should blame our teachers. Maybe we should start with my mentor. The blame goes to my mentor, Professor Bode Akindele. And I'm sure you know him, you knew him, late Professor Akindele. They did a good job, and all the other psychiatrists in Nigeria. To come to your question, absolutely. The approach to treatment is biopsychosocial. Understanding, I mean, the severity varies from very mild, which you discover, and can be treated by environmental intervention, by counseling, family therapy, and so on. Very important. And we used to have an advantage in Africa, but that advantage is disappearing. We had a collectivistic approach to problem. Families are there to help and so on and so forth. This seems to be disappearing these days with all the fears or whatever. So trying to reclaim that can deal with the milder case, good family support, counseling, family counseling, understanding the kid, ensuring that we're able to make early diagnosis and intervention. Then we go, I agree totally. I work at the extreme. I mean, I'm a forensic psychiatrist. I work with adults. I'm at the extreme of the cases you're saying. So what I see are individuals who have failed all those. And so by the time they come to me, pharmacotherapy is indicated. By the time to come to me, other forms of intervention is indicated. For all of those, I mean, looking at cognitive behavior therapy, relational therapy, they're very, very important. So I agree totally with your comments, man.
Okay, thank you very much, Kunle. There's a question from Orode that you need to speak to, but I also have another question as well. What effect or what role does caning the child have in terms of course, as you probably know, back home, when we have children who are very stubborn in our own terminology, we tend to cane them a lot. Does that in any way have a role to play in managing those children? And then you can answer this question as well.
Right. I think I should be partial here. If I have the choice, I'll answer Dr. Doherty's question first before I come to your question. There you go. What is the best way to transition older teens into adult psych care when they have a diagnosis in childhood in Nigeria, for example? Do you advocate leaving them with child and adolescent psychiatry for a while? And for how long? Very good question. The question of emerging or transitional adults is a problem all over the world. And honestly, it is a resource problem. It is a resource problem because there's inadequate resources. If you look at around you, that seems to be the problem. The child psychiatrists are always wanting to transfer patients, and the adult psychiatry are saying they're full, and so on and so forth. What's important here? The child becomes the center. If the adolescent psychiatrist or child and adolescent psychiatrist is willing to continue to manage and willing to transition them, I think it's quite individualized in your environment. I don't know what happens in your environment. What we are trying to do is we create, for instance, in the anger disorders clinic when in Ottawa, I saw a lot of 17 to 18-year-olds, and the child psychiatrists continue to see them because it's a specialized clinic. So they send them to me, and I transition them into adult psychiatry. So that helps. What I'm saying, it depends on the resources you have, the rapport the patient has, the trust they have with their treaters, and the family involvement. That will be the significant factor. I hope I've answered your question. It may not be so culturally relative, but that's the best answer I've got. What is the role of caning?
Thank you.
You're most welcome. I'm inviting you back to my program again. What's the role of caning the child? The good book said, you spare the rod and do what? Whatever it says about it. For me, what's out there epidemiologically, the more you cane the child, the more psychopathic they become. Fela was a good kid. Daudu was a strict father. You touch the wall, Daudu canes you. Fumilayo was a loving mother. Fela desperately wanted to leave home. A brilliant boy. When he left home, what happened? Everything went down. Brain. The story of Fela, you know. And you discovered it, the strictness of how the father was so strict. I know there may be individuals related, but it's a typical case of how parental physical aggression can change the personality despite the intellectual power of the child. So there are better ways of discipline than caning the child. Caning the child make a monster of the child. You saw from the study, where you have aggression, you're creating oppositional disorder, oppositional behavior. Oppositional behavior leads to conduct behavior, lack of empathy. If the person that I trust most, my parents, cannot take care of me other than with cane, inflicting pain on me, then how do you expect me to be able to empathize with others? Thumbs down for caning. There are other ways of training the child. Spare the rod and make a good personality of the child. That's what I would say. you're not spoiling the child.
All right. Thank you very much. I don't know if there are, okay, I haven't seen any questions apart from what we've seen before. So if there are no more questions, we would like to round up. But before we do that, we'll need to hand over to Dr. Mobolaji Lawal to say one or two words.
Yes, thank you, Sinde. Nothing really to add to what I had said at the beginning of the meeting. Only to thank Professor Ahmed for a very, very useful and interesting lecture. So clearly presented. It's of relevance to general pediatricians and primary care pediatricians as well. Because we are the ones that will spot these children early and take the necessary action before they become his problem, or they become his patients. So thank you so much. And I acknowledge especially Professor Grange for her presence and for her contributions. Thank you, everyone.
All right, thank you very much, sir. And to Kunle, thank you very much for sparing the early hours of this morning to be with us. I know it's about 8 o'clock or 9 o'clock in Canada right now. And don't worry, the fact that I was chasing you on the phone, because I had to be sure you are up and ready for the lecture today. And we want to say a big thank you. I know at some point in time, we'll call you again to speak to us. And please, the invitation to Dr. Orode should not be to her alone. You can call the rest of us and we shall present at your programs as well. We want to say a big thank you to you. And with your kind permission, we'll share these recordings to other members of the group who are not available here today, so that, we can all benefit from this lecture. And also we'll be putting this on YouTube so that other people can also benefit from it. So a big thank you from the class of 86.
Thank you very much.
We shall meet at our usual venue.
You bet.
To continue. So thank you so much. Our next meeting will be on the 9th of June. And we're going to have another exciting presentation. So thank you all, and God bless you all. Thank you very much.
Sir.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Thank you very much.
Thank you. Bye-bye.